And so I want to introduce, there we go. Dr. Nick Pashos founded bioaesthetics to improve people's lives through tissue engineering. Prior to bioaesthetics, Dr. Pashos attended Drexel University, where he earned a bachelor's degree in biomedical engineering. He then worked at Massachusetts General, tongue twister there, in the Institute of Neurodegenerative Diseases. He completed his PhD in bioinnovation at Tulane University and as a Natural Science Foundation Fellow. During his time at Tulane University, Dr. Pashos became aware of the lack of satisfactory reconstruction options for nipple reconstruction following mastectomies and the adverse effects it had on millions of breast cancer survivors. He began developing a graft to regrow the nipple and areola, creating the foundation for bioaesthetics. Dr. Pashos' research background has been focused heavily on tissue engineering and biomedical materials, from a unidirectional cell-guided growth in biomaterials for spinal cord injury repair to whole lung regeneration in bioreactors to in vitro 3D scaffolds for tumor research, to developing the bioaesthetics nipple areola complex grafts. So LOPA has been working with bioaesthetics for several years now through their research phase. We have asked donor families to consider donating the nipple areola complex, and bioaesthetics has been able to use this material to forward their research. And so I'm sure Dr. Nick will be able to explain a lot more. So without further ado, Dr. Nick.
Thank you very much, Kirsten. I just want to take a moment and just thank LOPA. We've been partners since about 2017, and without their support, we really wouldn't have been able to bring bioaesthetics to a clinic at the end of this year, actually. And most importantly, the donor gifts as well. I think just without those individuals and those individuals, families, life-saving and life-enhancing surgeries just wouldn't exist. So, my sincere thanks to all those donor gifts, just in general. So I'll just give you a little background about bioaesthetics. Bioaesthetics, nipple and areola complex grafts, and then one very popular question that I've always received, being a male in the breast reconstruction industry, is how did I end up, regrowing nipple and areola complexes? So I'll give you some background on how much led me to nipple and areola complex reconstruction. So from here on out, please call me Nick instead of Dr. Pashos or anything. And I'm the founder and CEO of Bioaesthetics. And at Bioaesthetics, we're really with our novel product being a nipple areola graft for women who've undergone mastectomies due to breast cancer. So this nipple areola complex is a regenerative human-derived graft that, once engrafted onto a patient's reconstructed breast mound, would allow for the patient's own cells to grow into it, reestablish a blood supply and skin within about 6 weeks, essentially giving them a brand new living nipple and areola complex for that patient. And so, just to give us some background on how I got there. So as Kirsten said, I was working at Massachusetts General Hospital. I was working in the Institute for Neurodegenerative Diseases, and I decided to go back to get a PhD. I was reading a paper in the Boston Library about whole organ transplants or organ donations that wouldn't be able to be transplanted due to disease, a physical of that organ. And what they were doing was removing all the cells and DNA in a process known as decellularization for whole organs such as lungs and parts. And this paper was about lungs in general. And they were then taking the patient's own cells, in this case a large animal, taking their cells and regrowing an entire organ to be essentially a supplement to organ transplants in the future. And I thought that was absolutely fascinating. I thought that if I needed to spend a career on something, that was what it was going to be. And I've actually had a lobectomy, so I've had a lobe removed as well, and had chemotherapy and everything else. So I was like, you know what, if I'm going to dedicate my life on something, it's going to be lung regeneration, and that's it. So I found this lab down at Tulane University in Bruce Bunnell, at Bruce Bonnell's lab, focusing in regenerative medicine. And I decided that's where I'm going to go. I've never been to Louisiana. The only thing I knew about it was from the show Swamp People, living in New Hampshire and Boston. And it was definitely a change of pace, but it was absolutely changed my life being down there and meeting such incredible people. And while I was at Bruce's lab, I focused on lung regeneration for about 1.5 years. And I found it absolutely fascinating, loved it. And then one night I was watching a documentary on Netflix about 1 or 2 o'clock in the morning, and they started talking about mastectomies and not having nipple and areolas anymore after that mastectomy. And I guess that's just, you know, I wasn't educated in what a mastectomy really was. And so I stayed up all night reading about breast cancer mastectomies. And it was truly remarkable that there are more than for nipple and areola reconstruction for those women. They can have a tattoo, great, but there's no depth to it and it's not living. It fades about 40% over the course of 2 years, from my understanding. They can have a prosthetic, so they can have a rubber nipple and areola complex that they take on and off at nighttime. Also non-living and non-permanent. Or a patient may undergo a surgical reconstruction where a surgeon will take skin from a different part of the body, such as the thigh, the arm, or even the breast tissue, and suture up a nipple-like structure. And what I learned that night was that about 70% of that first year disappears because of remodeling within the patient's reconstructed nipple. Within 5 years, most of the time, there isn't much of a nipple left over instructions. And so people are kind of left with something that's non-permanent. And, you know, that was kind of something pretty remarkable to me. You know, breast cancer cases, you know, women have 1 in 8 chance essentially of getting breast cancer. And there were more than 260,000 new cases each year. So I thought that I could take what we were doing in the laboratory at Tulane University and transfer over to nipple and areola complexes by taking tissues and removing all the cells and DNA. So essentially leaving a cell-free graft from a donor tissue and being able to transplant it onto a recipient. And this had been done previously. They're used in abdominal wall reconstructions, they're used in tendon repairs, but they'd never been used on the outside of the body before or for nipple and areola complex reconstruction or donor nipple and areolas. So I walked into my boss's office the next morning around 8 o'clock, and I laid out this massive plan of restarting my PhD and focusing solely on nipple and areola complexes because there's a true need. And it was interesting. That night kind of switched what my passion was. Before was lungs, because it's something extremely personal to me, to finding out that there was this massive group of people who were just having, you know, could have a better reconstruction process at the end of the day and have a truly quality of life enhancing product as well. So my boss looked at me, he asked me if I was serious, and I said, absolutely. So we went to go find some Chafin at Tulane University. And she basically just said, yeah, there's an absolute problem. And that every single surgeon who reconstructs the nipple, they reconstruct it in a different way. There's 85 different ways to reconstruct a nipple, and not one way works absolutely perfectly. And every time she tries to reconstruct a nipple, she always tries to do better and better because there's no standard of care currently in the field. And so from that meeting on, I over and said, all right, how am I going to start transferring this out from a university setting out to you know, patients? The best way to do it started in 2015. I started Bioaesthetics as an LLC to just try and get some handle of what was going on and having an opportunity to go out and actually speak to breast cancer survivors. And I gotta say, breast cancer survivors are some of my life. They are very resourceful. They reconstruction, methods of reconstruction, of nipple reconstruction, treatments, and so forth. tremendous amount of in total. I think I spoke to well over 100 individuals, just trying to get their feedback on something, if a nipple and areola complex was something that was actually needed, and if it would actually be used. And it was very interesting. Process. I also learned about donated gifts and donor gifts in general, and the American something going through and speaking to some donor families and understanding that, and other procurement agencies as well, and truly understanding kind of what that process is and what that means from a donor to a recipient, and what that truly means and how that changes people's lives. And it was educational. I think I started this in 2013. So educational, like from both breast cancers, from donor families, from recipients of donor tissue. It's been really tremendous. So that's how I ended up in nipple and areola complexes. And biosthetics has been focusing on and clinical model, showing that it can work, safety and efficacy, showing that we can actually grow blood vessels, regrow full thickness skin, and also potentially have sensation for those patients in the future. So right now, biosthetics has been transferring everything over from research grade to transplantation of tissues with our tissue partners, our organ procurement partners, and that's what we're in the process of doing right now. We've also been working with partners throughout the country for processing as well, to make sure that how we process the tissues is in a safe and efficacious manner that produces a cell-free graft that is free of communicable diseases. So when we go forward towards clinic at the end of this year, we'll be able to give the recipient the absolute it wouldn't be without those donors and the organ procurement agencies. So that's a little bit about biosthetics, about the nipple and areola complex graft.
You said that you guys are in the process of transitioning from research to the actual transplantation to humans?
Correct. So we're currently in the process of transferring over all of the tissues from research to transplant tissues, because we'll be going forward to clinic at the end of this year and the beginning of next year, and that's when our first patients will be engrafted.
And so is that still part of the clinical trials? Like, what's the next phase of trials?
Yeah, so it's not technically a clinical trial. We don't need it in order to actually get to market. So because it is a human-derived tissue, it is considered an HTTP. So it is purely a clinical marketing study, essentially. It's really to evaluate an extra sense of efficacy within a patient population moving forward. And that's in order for us to go forward for more of a widespread throughout the rest of the United States as well. So we're focusing on one center, and then after that clinical marketing study, essentially, then we'll be able to go forward beyond there to our early adopters as well.
Nick, one of the questions I had gotten was, can someone that's already had a mastectomy, that's maybe had one of those other types of reconstruction that you talked about, be considered for a NAC transplant?
Absolutely. So it actually doesn't matter how far off from being reconstructed. If it's 1 year, 2 year, or even 10 years away, previously reconstructed, they can have a nipple and areola complex reconstruction. For people who are undergoing current reconstruction, it will be generally done at the last phase of breast reconstruction in the operating room. But the way that the nipple and areola graft is going to be engrafted onto patients is that we are just removing the top layer of skin, so just the epidermis. There's not a full thickness wound that's being created, and the NAC graft is being placed directly on top of it and sutured into place. So you don't create a full thickness wound. There's less of having a potential infection in the breast implant underneath the tissue as well, because you still have the barrier of the full underlying skin of the dermis left intact.
With our organ recipients, most of them are on anti-rejection meds. Do you have to take any anti-rejection meds for this type of transplant?
You do not. So this type of transplant, it has no cells from the donor. It's basically the proteins of that tissue still intact in the exact same shape and size of the starting tissue. But because there's no cells or DNA left over, it doesn't elicit an immune response. So as the patient's cells grow into it, it essentially becomes part of that patient's body.
Okay, so another question that I've heard when I've been telling people about the NAC, do you have to match, are y'all going to try to match up skin pigmentation, or is that removed in that decellularization process you were talking about?
Yeah, so there is a matching process. It's actually mostly based off of size. So what we hear from patients and from physicians is that patients have a preference on how large or small they would like their breast and also the nipple and areolas. And so that is something that we are able to match based off of patient preference and surgeon's preference as well. As for coloring, so we actually don't remove all the coloring during it. It stays in the epidermis. So the melanin within people's skin, it stays in the epidermis. But what we see is that it really takes the graft takes on the patient's own skin tone. So whatever your native skin tone is, that's what we expect it to be. It'll be likely a little bit darker just because of the amount of skin cells in the area, and also a little bit pinker because of the amount of blood vessels underneath the skin as well. But that is something that we'll be looking at as we go forward into clinic and evaluating it as well to see if we do need to modify coloring ahead of time to match patient preference. That's something we would be able to do later down the road.
Are insurance companies receptive to this procedure? Basically, will they cover it under their plan, or are they calling it an elective surgery?
Yeah, so right now what we're going forward, we'll be trying to go forward for our own reimbursement code to make sure that all insurance reimbursements essentially cover it. But in 1998, they passed the Women's Health Care Act that basically says that insurers or payers need to be able to cover and pay for mastectomy and also the reconstruction of that after that mastectomy, including the breast and the nipple and areola complex. So right now, there are reimbursement codes that already exist that cover the surgeon's time, the operating room for nipple reconstruction, even some generic materials that may be used in nipple reconstruction. So the question is, going forward from it, is to be cleared underneath that as well, or maintaining our own reimbursement code as well. So that is something that we're going forward with, and you really need to have clinical data in order to achieve that. So that's one of the reasons why we have a set of patients that will be going in a clinical marketing study towards the end of this year.
Is this similar to a skin graft without the other skin layers?
Essentially, so it's very, very similar to allografts that they use right now for abdominal wall reconstruction. Actually, a perfect example is they generally use allografts or donor skin tissue, donor dermises, within 61 to 75% of all breast reconstructions currently. So right now, majority of breast reconstructions utilize donor gift materials within their breast reconstructions. And it's very, very similar to that, where those are just dermis derived. We use the dermis and epidermis derived grafts, essentially, full thickness.
How soon after the nipple areola is recovered does it need to be transplanted?
Yeah, so it can be transplanted. We've utilized them up to about a year afterwards, actually. So they have a very, very long shelf life. Once the cells and DNA are removed, they essentially will be just in the refrigerator or freezer until usage. So it has a pretty nice shelf life, just like the majority of any other allograft.
What happens if the graft does not take or the body rejects it?
Yeah, absolutely. So although the body rejection is very, very low, the chance, obviously, it's a tissue graft, so it could happen. So if it doesn't, if it's rejected or infected or anything negative, as simply just be removed. So like I said earlier, as we were discussing, we don't create a full thickness wound on top of the patient. We just remove the top layer of skin, which is extremely thin, leaving a dermal bed. So if you remove it, it would likely be reepithelialized, and you can go on to get another graft or have a traditional nipple and areola complex reconstruction with your surgeon.
Will the recipient have any nerve sensation in the area, if at all?
Yeah, so in our preclinical studies, we show that about 66 to 67% of all the grafts do have the presence of nerves within it, which gives it the sensation. This is going to be heavily dependent on how someone has a mastectomy and a reconstruction. If someone has a skin-sparing mastectomy, there are generally nerves in the area. If somebody has a total or radical mastectomy where they remove almost everything, even down to chest muscles, that patient is going to have a very different healing process than someone that has essentially a skin-sparing mastectomy or only a partial or a lumpectomy. So if the nerves are in the area, we have shown we won't inhibit them, but if the nerves aren't in the area, it's very difficult for someone to have sensation. And a lot of breast cancer survivors who undergo complete mastectomies and reconstruction have sensation issues, either lack of sensation or dulling of their sensation in the breast. So it's going to be really patient dependent, and that's something we're also going to be evaluating moving forward.
What would the healing time be for recipients?
Yeah, so right now the healing time would fit into the same healing time for breast reconstruction. What we expect is that about 4 to 6 weeks essentially for it to be completely healed, where you have full thickness skin and blood vessels within the graft.
Could this also be utilized for women who have had breast reductions and their nipple areola did not reattach post-surgery?
Absolutely. This is something that, women may even have nipple-sparing mastectomies during their mastectomy, which they'll try and save the nipple and areola complex. But sometimes that nipple and areola becomes, there's a lack of blood supply and it needs to be removed. So in cases where there's a reduction in the nipple, they need to be removed later down the road, or in a nipple-sparing mastectomy where a nipple may need to be removed. The Biostatics NAC graft would certainly be able to help those patients as well.
Will your company facilitate communication between the donor family and recipient if each are willing?
Absolutely. So that is something that, we've been working with the procurement agencies, and going into this, I didn't actually realize that that was even an option. And I remember going into one procurement agency where they had sort of on the wall hanging kind of letters back and forth and communications, and that will certainly be an option moving forward with our company as well for this the NAC graft.
Does age matter in the success of the transplant? A graft from a younger donor would work better for a graft from an elderly. A graft from a younger donor better than a graft from an elderly donor?
So what we've seen actually is that that's not necessarily the case. Is that the proteins within it are actually pretty good no matter what age, from what we're seeing preclinically. So we do have cutoffs, making sure that we have adults always, and we don't expect that to be a problem actually.
I just want to chime in and say that, we're all kind of monitoring the chat and we're hearing all the questions and we're responding and we're all kind of just taking it all in, and it's so amazing. In the meantime, my phone is blowing up with, "This is amazing. I can't believe this. I believe I even got it. Dr. Nick is the man." So everybody's being very respectful and staying on mute, but every time these comments are coming in and people are just in awe of what you're teaching us tonight, and I can say that I am myself as well. So I can't thank you enough.
Our CEO, Kelly Ranum, has been incredible in supporting our research efforts, and for us to always be looking for ways that we can improve the health of others beyond traditional organ donation and transplantation. Kelly, if you're on, I'm not sure if you want to say anything.
I'm just really honored that you decided to work with us, and it's been a really fulfilling project for all of us, and I think a great way for our research department to make its mark. So I thank you. I've learned a tremendous amount, and you are a fantastic presenter because nothing has stumped you. So I'm really impressed and grateful for your time.
Great. Well, thank you guys very much, and thank you again to LOPA and also the donor families. LOPA has been a partner of ours since pretty much the very, very beginning, and we honestly could not have done it without LOPA, just in general. So I'm incredibly thankful to you guys. You guys have allowed us to bring it to clinic, and hopefully we'll make a lot of patients very happy moving forward together.
Thanks again, Dr. Nick. We really appreciate it.
Thank you for having me. I really appreciate it.